What is life if you're not healthy? Digital technologies is empowering healthcare to a new degree, and we believe that health tech plays an important part in the future. Our next speaker is the co-founder and CEO at Cortrium. He holds the rare combination of having a degree in medicine with a license to practice independently as a medical doctor and a master's degree in biomedical engineering. In his early career, he already focused his work on improving patients' outcome by leveraging scalable new solutions. In this work, he has been active in organizations aiming to advance technology and medicine, such as Health 2.0, Hacking Health, and Startup Buzz. Before that, he made clinical experience in the fields of neurology, cardiology, and emergency medicine, and has 1.5 years of research experience in neuroscience. Today, we are proud to have this digital leader with us in Luxembourg. Please welcome Mr. Dr. Erik Poulsen.
Thank you very much for the kind introduction, Katharina. It's true, my name is Erik Poulsen. I am a medical doctor and a biomedical engineer. I come from a company called Cortrium. We're a medical device company, and what we produce and what we try to do is to change healthcare through open and accessible technologies. Today, I'll not talk much about what we do in Cortrium, but I would rather focus on optimization within healthcare using novel technologies. First off, let us have a little peek into the opportunities, but also challenges within digital health. So great opportunities are arising anywhere within tech right now, especially the access to abundant information, the internet obviously, and also the fact that a lot of open source projects are being created and are being used. Actually, I've heard that some programmers, they say, you don't program anymore, you just go to GitHub and then you make a copy of the code, change a little bit what you need, and your job is done. So this is a beautiful way of advancing technology where we are saving a lot of time and effort. I want to point out that within hardware, which has typically been really, really slow, the iterations you can make and the prototypes, we're seeing great advantages in new technologies. You have all heard about these 3D printers and also cheap ways of doing fast iterations. So this is highly important in healthcare, where hardware is sort of an essential thing usually. We need to measure the patients. Anyways, I also want to talk to you about the massive demographic challenges that we're facing over the coming years. Furthermore, the swift adaptation into clinical practice. And I do this, and I did put a question mark in there, because is it that swift? I'll look a little bit at that. Furthermore, novel technology to the rescue. Is that true? And if so, how will this be used? You've probably already seen some exponential curves during this conference. If not, I'm sure that you will. I have brought my two favorite exponential curves along. The first one that you're looking at is really staggering to me, and just proves that technology can do amazing things over a short period of time. It's related, and it's the one that you're looking at on the left-hand side. It's related to the cost of sequencing DNA, sequencing the human genome. If you look at the y-axis, and bear with me, there will be some curves in this presentation, but I hope you'll follow along. If you look at the y-axis, it might be hard to tell, but you have the cost per sequenced genome, and this cost is incredibly high. Actually, you see that the line is falling, and you have to pay attention that the scale is logarithmic, meaning that a straight line is actually an exponential decline in cost. And on the x-axis, we have the timeline going from 2000 to around 2011. And what you can see here is that it's exponentially dropping. The other line is actually Moore's law, you see there. And something really fascinating is happening around 2007. Here we see a drop from the exponential drop, which means that it's really going fast with getting the prices down for doing genome sequencing. So that's really fascinating and just a testament to how rapid this can go. The other one is regarding the information and how much new knowledge is being produced. Medline, where I have this curve from, is a database indexing scientific papers, peer-reviewed papers. And the amount of new knowledge going in there all the time is incredible and also exponentially rising. And it's been known for a long time that you, as a doctor, cannot really know it all. And even if you're in a very narrow field, you cannot simply not grasp it all, which is why we're seeing emerging technologies and especially artificial intelligence coming in to help us with decision making. Okay, now I'm going to introduce you to one of the big challenges, and this is what they, in the UK, refer to as the silver tsunami. And the reason for this is the demographics. So if you look at these two shapes, they represent the population indexed by age groups. On your left-hand side, you see in 2010, the population. And look at this nice fat shape of the population curve, where we have the majority of the population in their working, or in the age where they're capable of working, between 15 and 65. This is really good because the top of the shape is kind of narrow. So this means that we have a lot of able working hands to care and to work for the population that might need it the most, typically the elderly. If we then fast forward to the prediction for 2060, we see that this nice fat shape has sort of been squeezed together and a lot of the population has been pushed upwards. This means that we do not have enough able working hands, especially within healthcare, in order to aid and care for the elderly population, hence the silver tsunami. Actually, it has been predicted by the World Health Organization that the population above 65 years old in 2012 was 17%, whereas in 2030 it is estimated to be 60%. So again, I stress to you that this is a major challenge. How do we care for these people? Next major challenge, it's a little bit depressing with all these challenges. I tend to call them challenges and not problems, but you can judge for yourself. Anyways, doctors are known to be skeptics, and it's really, really a rigid system. Very hard to implement new technologies. The NIH has acknowledged this, and they have even made an average measurement of it taking 17 years for already proved research to be fully implemented into clinical practice. So that is definitely also something that is a little bit worrying. If we do look at the technology adoption of the general population, and a previous presenter touched upon this also, we see on this curve, on the y-axis, we have the years it takes for 1/4 of the US population to adopt a new technology. And on the x-axis, we see a timeline where we have points in time where the first commercially available product of this new technology became available. And as you can see, electricity took 46 years for 1/4 of the US population to adopt that, going down to television around 26 years, private computer 16 years, and the World Wide Web, which is the latest on this curve, 7 years. We already heard from the previous presenter that you have adoption rates of, for example, going from a classical mobile phone to a smartphone of just a few years. So it's really not that big of an issue in the general population compared to what it is in the clinical setting with doctors mainly. What has, though, happened in the clinical setting is since the 70s, a lot of administrators have been put into the system. We see the gray line down here with the increase of physicians in the system. This is the US system, by the way. And we see that from around the 80s, 90s, we have a lot of administrators. Have they really fixed the problem? Not yet. At least we can tell that the percent growth of healthcare spendings per capita in the US has also steadily increased in this period of time. So we tend to sort of focus on technology when we're looking for answers. How can we deal with these upcoming problems? And one thing that has been incredibly popular over the last, say, 5, 6 years is wearable technology. This was sort of meant to be at least part of the salvation of this problem. We should simply measure a lot of people, measure a lot of things. It would give us great information and people would not get sick. However, as it turns out, this has not really been the case. Actually, Jawbone, one of the major manufacturers after Fitbit for this kind of wearable technology, has in November, they ran out of inventory, and just this Monday, they announced publicly that they are quitting consumer wearable devices in order to produce clinical devices. And this is interesting to me, as we in Quatrium always have figured we do not want to do consumer wearables, we want to do clinical devices only. The reason for them making the switch is that they had a lowering of the valuation of the company from actually around a third of the value it is now compared to earlier. And this has to do with the fact that the margin is low on consumer electronics. For example, these wristbands that they're selling, they would go for $200. Now they have to sell them for around $50, which is hard to monetize. So, and it also goes to show that the hardware in itself is not really where the value is at. The value is at producing meaningful results and actionable results. So very interesting, I think, that you see the big companies switching towards clinical grade technologies and not putting all of their eggs in the basket that is related to consumer electronics. It has also been shown that with Fitbits and other activity trackers, people simply lose interest. Or many of you have probably had an activity tracker, and many of you are probably not using it anymore. After 2 years, less than 50% will still keep on using their activity trackers. And why is that? If we look at the reason for this disengagement, we see that it is highly related to limited functions and that it isn't standalone. To a doctor or anyone within the healthcare system, the fourth reason is the most important one. They simply lack to produce accurate data and information. And this really is the worst case if you're a doctor. If your patient will go to you and he says, I have been tracking myself over the last period of time with all of these wearable devices. I now know how many steps I'm taking and how many calories I'm burning. And something is happening. Doctor, please tell me what's going on. I need you to put your mind into this. Your doctor will definitely sort of run away screaming if he had the chance, because these are new measurements, these are not validated measurements, and they aren't actionable. You can't really use that information for very much when you're a doctor. So doctors tend to be skeptic and do not want to engage with this new technology, even though it over time, I have to admit, will most likely deliver promising results. But I think we're right now in the emerging technology hype cycle. We're right now around this point. Actually, with regards to wearables, I would say that we're a little bit disappointment right now. But this is typical. The great presentation regarding virtual reality, I also think, is a nice example of this hype cycle that we usually see. I remember me as a small kid being really excited. Now virtual reality is coming. And here we are 20 years later, and now something is finally happening, and we're starting to see the amazement. This will very likely also be the case with wearable medical technologies. It is predicted that by 2021, 1 out of 5 Americans will, though, use this wearable technology. And the market will pivot, as we've seen with Jawbone, from fitness into healthcare. So people do not really want to live or to being reminded to be more fit or more wellness-related measures. They actually want to lead healthier lives. Very interesting new study, and it's only a week old, as you can see. But going into healthcare is definitely not easy. I like this slide because it tells you a little bit about how non-transparent and convoluted the whole system is. For example, and this is focused on the US, but I think it holds resemblance in all countries, basically. But healthcare is the one industry where the person ordering the service does not use the service. The person or patient receiving the service does not pay for it. The provider of the service does not determine what they get paid for the service. And finally, the payers for the service determines the price, but they do not receive the service. So as you can see, it's kind of hard to build new models around this because it's non-transparent and pretty convoluted. Current situation in healthcare, and this is highly inspired by our lead of the telemedicine group in Denmark, Claus. He put this slide up in 2012 at a TEDx conference, and I've brought it to you guys also because what we really want, the big dreams of healthcare, is that we have instant access, everyday access to healthcare. However, what we're seeing is gatekeepers and endless waiting. Actually, the prime function, I don't know if I should tell you this, but a family doctor, he has a primary function of keeping people out of the secondary healthcare system. So his rule of thumb is you can only let 1 out of 10 patients go through the system. That's how it is. Also, the dream is we have high quality of healthcare. However, what we're seeing in the hospital, perhaps you've seen, especially in the UK right now, doctors are really crying for help in this system that is really overloaded at the moment. So we want this high quality healthcare, but the way it's set up with the incentives is budget driven, and that really takes its toll on the patient experience and quality. We also want to empower the patient. However, the role of the doctor is usually not really empowering. It's not saying, yes, bring me your special data from your wearables. Should more be teaching you what to do and trying to control you. Furthermore, you would want access to your own health data, and we have a lot of privacy talks going on. This is how it should be and will be, I'm sure, but still it's unavailable to you in many cases, your own health data. This is just not right. Also, as a big system, we want all the effort put into your care to be coordinated and to be coherent, but it is fragmented. And generally speaking, the whole healthcare system is extremely siloed. And this siloing means that instead of having one point of contact in the hospital, you might very easily fall in between these sectors. Most patients, when they grow older, they do not suffer from one disease and have to go to one department. They suffer from multiple diseases, and they would have to go to multiple departments, and the system is not built for this. The system is built for you breaking a bone, getting it fixed. That's pretty much it. Furthermore, we would want healthcare to be moved to the patient, yet we do see that patients have to travel long distances to receive the healthcare. So that's pretty pessimistic, I have to say. At Quadrium, we do try to change this, and we have sort of a design mantra. What we do is we focus on precision, meaning that no fitness, no wellness. We only do approved devices with clinical approval and prove the accuracy. Furthermore, it's important to focus on the purpose of the device, because it needs to be something measurable and also something actionable. Furthermore, the people. Are we targeting patients? Are we targeting healthcare professionals? And we are aiming more at patients, and this has to do with the demographics you saw earlier. We cannot rely on a healthcare professional being able to help you all the way through your disease or your diagnosis. We're also very focused on the place where the devices should be used, and here we're targeting more home use, even though it is clinical grade, compared to hospital use of the exact same reason. The payment, this is a strong incentive in all of the system. So we really try to develop something that is fitting right into the existing reimbursement system. And what we have created, I have one in my pocket, and our first product that we will be launching in Germany is a vital signs monitor this small that is clinical grade, and that will enable you to get the same measurements done at home as you usually have done in the hospital. Heart rate, how many times you're breathing, temperature, also accelerometer data, and finally we're putting in blood oxygen level and blood pressure. And all of these 5 and the added accelerometers are so important vital signs. You can tell a lot about a patient's health, and this is the standard of care to have this measured in the hospital. Once you can do this in the home of the patient, you can sort of transfer a lot of the costs that would be spent in the hospital into other more important places, and you can start to look at the patients in their home. So we want to be able to give the instant diagnosis and a better patient experience, still with a connection to a human physician in order to guide you. And we want to do this at a lower price, which is definitely possible. This is, by the way, my grandmother. She's 92 on her 92nd birthday on this picture. And if she can use the device, I think we've hit the target with regards to the people and the ease of use. Really quick, the current trends in digital health as I see them. We are probably going from monolithic systems, really big hospitals trying to take care of all, and then into a more microservice structure where you see companies that are really specialized in just handling one thing and doing that really well. And this should be all created as end-to-end solutions so that the big systems can plug into it and say, we outsource this diagnosis to this company. Furthermore, really pleasant to see and to experience is that open standards are becoming the standard, and also that you now need to have some scientific journals. They will not publish your paper unless you give full insights into the data, so you can reproduce the scientific work. Also, full insights for the patients of their own data. That should be a given. What I'm also seeing is that we've sort of also with Wearables tried to push some technology to the consumers in order to have the consumers go to their doctor and then push it to them. So we instead of trying to pushing this to the doctors, we're seeing that the idea at least is patients should create a pool of the technology from the doctor. But this has proven difficult, again, because doctors are generally skeptic, especially for new measurements. My final big question would be related to the adaptation rate. And if anyone has any examples, and it doesn't have to be within healthcare, just within a complex big system, could be any public sector or any public system, I dare to say, how do we speed up this adaptation rate going from incremental and very budget-driven into rapid and performance/value-driven? That's my concern, and that's what keeps me up at night. Those were the words. Thank you very much for listening.